Welcome everyone to the 2021-2022 Big Ideas Competition pitch event. My name is Allie Cazador. I'm the director of the Healthcare Innovation Lab. I am helping from an MC perspective today, but the real champions behind the scenes are my colleagues and partners in crime, Kayla Hurley in the Command Center and Jackie Jones. This is the first time that we've ever done this virtually, and so we really appreciate everyone's patience and understanding as we coordinate technology and this new normal of virtual. So again, thank you so much for taking the time to be with us here today. I'll go ahead and advance the slide. And so today's run of show, the event today is being recorded, and we note this just as part of any sort of consent of a session being recorded. We wanted everyone to know that this event will be recorded and shared throughout. All attendees have been muted. So what we will be doing behind the scenes is unmuting and muting the panelists, the presenters for each pitch, as well as for the judges during the Q&A session. Closed captioning is available, and you can see that at the bottom of the Zoom screen to activate. Depending on the version of Zoom that you have, it may be at the top of your screen, it may be at the bottom of the screen. That is available. Each team will have 3 minutes to pitch their big idea. This is all timed. And so we will be working with each team to make sure that they stay on that time frame to allow for 5 minutes of Q&A with our pitch big ideas judges. During that 5 minutes of time, we'll actually be asking our attendees to participate in a Zoom poll. I'll launch that in that same Q&A session. You should see that automatically pull up as part of your participation as an attendee. And after the 5 minutes, I'll close each of those polls, and we'll go into a 1-minute transition period between each of the presentations. That 1-minute presentation transition will allow for us to mute and unmute the next presenters, as well as share the results of that poll. The poll itself asks similar questions to how our judges are reviewing each of the pitches. And so you'll see a screenshot of an example on the left-hand side of your screen there, and we're very excited for you to participate and further enhance our assessment of each of these presentations. So with those logistics out of the way, I would like to transition to Tom Maddox for our opening remarks. Tom.
Oh, hold on.
There we go. Thank you. All right. Well, thanks everybody for attending. For those of you who I don't know, I'm Tom Maddox. I'm a cardiologist at WashU. I'm also the executive director for the Healthcare Innovation Lab. And I'm excited to welcome you to our third Big Ideas competitions, co-sponsored by us here in the lab and our colleagues at the Institute for Informatics. And as you guys know, this competition harnesses the ingenuity of our WashU faculty and BJC staff to use digital information and technology to improve the outcomes of the patients we serve. And to date, this program has awarded 13, actually I take that back, 15 $50,000 grants. We awarded 6 in the 2019-20 academic year, 7 in the 2020 and 21 year, and then we had a special COVID-focused Big Ideas competition at the end of last year and awarded 2 grants there. And all of these grants have really had just amazingly innovative uses of digital health techniques, such as predictive analytics, wearables, and voice assistants to rethink how we deliver care here at BJC and WashU. These projects have also spanned the breadth of our clinical enterprise. They've involved radiology, palliative care, critical care, anesthesia, surgery, emergency medicine, pediatrics, orthopedics, oncology, and primary care. So really looks at the full patient population and care teams that serve them. We also, envisioned early on that this program would support early stage ideas that maybe were years away from really being operationally viable. But we've actually been really gratified and amazed to see that some of these ideas are already impacting clinical operations and their outcomes. One example I'll point to is what's called the Total Goals of Care program, which was one of the grants that we funded in our 2019-2020 Big Ideas cohort. So this team was from palliative care. It's led by Nathan Moore, who's a primary care physician with the BJC Medical Group, and Pat White, who directs our palliative care services at WashU. And they sought to use predictive analytics to proactively determine if patients reaching the end of their life were receiving care concordant with their wishes. So to do this, they had developed a highly accurate predictive model that proactively identified these patients while they were inpatient, while they were in the hospital. And then with that identification, Nate and Pat and their team would reach out to the teams taking care of those inpatients to encourage them to have the conversation, to clarify the patient's wishes for their care, and then tailor their care plans accordingly. So they've been live in our system at 2 hospitals since January of this year. They've identified well over 200 patients who are approaching the end of their life, and they reached out to almost all of those teams. And of those teams they contacted, over 90% responded and went ahead to have the conversation to clarify the patient's wishes. Nearly half of those patients, because of that conversation, significantly changed the care plan that they were receiving. And they, for instance, engaged palliative care for their help, sometimes even electing home hospice. But in all cases, making sure that their goals of care were visible and front of mind for the care teams and their families to make sure we were respecting those. And I think this is a great example of the program fulfilling our goal of supporting ideas that use digital health tools, such as predictive analytics, to partner with our patients and care teams to ensure that we're giving them the best possible care in the manner by which they want it. So today, we're excited to hear from the next set of new ideas. We have 11 teams. They've already been through one filtering process, so you're seeing the best of the best. And we're going to hear today the pitch that they have on their big idea. And importantly, you guys have a voice in this selection. You will see the polls come up as you hear the various presentations, and we really encourage you to participate. We also have some wonderful judges today who are helping us evaluate these ideas, and it will inform our overall decision about who gets the grants. The judges are Michael Avedon, who's the chair of our Department of Anesthesiology, Deb Odell, who's the chief data scientist of BJC Healthcare, John Lynch, who's a pulmonologist at WashU and is also the president of Barnes Jewish Hospital. Clay Dunnigan is an infectious disease doctor at WashU and is also the chief clinical officer for BJC Healthcare. Ebony Carter is an OB-GYN doctor specializing in maternal fetal medicine. She's also the chief of their division of clinical research. And then Thomas Cannonball is a really accomplished informatician based at the Institute for Informatics and also at the Department of Anesthesiology. So all of these folks have really deep knowledge, not only in informatics and innovation, but also in implementation and operations for our system writ large. I want to thank all of the teams here who are going to present today. You've put a lot of work into this, and we really appreciate your willingness to participate in the process. And then I also want to thank our amazing lab and informatics teams, or Institute for Informatics teams, who are responsible for everything you're seeing on the screen. I especially want to thank Allie, who you heard from the beginning, Jackie Jones, Kayla Hurley, and Megan Nelson here from the lab. And they got fantastic support from key people at the Institute for Informatics, in particular, Lucas Steinbeck, Laura Swafford, Lynn Zhang, and Carter Staley. And then finally, I want to welcome virtually our colleagues from Avia, which is a national digital innovation network of over 50 health systems similar to us. And we're all banded together to kind of share best practices in digital health innovation. They've dialed in today to learn more about the amazing ideas that our faculty and staff are presenting today, and see how this kind of work supports an overall culture of innovation on our campus. So with that, let's get going.
All right. Thank you, Tom. Can you guys hear me okay? Am I frozen again? I'm frozen again. Thank you, Tom. We are giving ourselves the 1 minute transition here.
And make sure we can.
Amy, are you able to hear us and speak?
Yeah, I can hear you. It's a little echoey, and I can't start my own video. I think you guys have to allow me to do that if anyone wants to see my face. Yeah.
Looks like Amy, your video is not able to be turned on.
Okay, it says the host has stopped my video, so.
Let's try that. Try that. Amy, try to turn it on now.
It still says the host has stopped it. I'm sorry to everyone for the technical difficulties.
No, thank you for your patience.
Yeah.
I got it clicked to allow panelists to start video.
All right.
Okay.
I think we're up
Amy,
and
it looks like we can see you. Is that right? Hi. Okay. And then do you want me to go ahead and advance the slide? All right, Amy, you're up.
All right, so my name is Amy Armstrong, and I'm a pediatric oncologist at WashU, currently strengthening our adolescent and young adult sarcoma program in coordination with Siteman Cancer Center. Our big idea is to evaluate step counts from wearable devices and PROMIS questionnaire responses. Great. Did anybody hear what I just said? We're good? Okay. Cool.
Keep going, Amy. Thank you.
Oh, okay. Did anybody hear my introduction or no?
Yes.
You
Yes.
did. Okay. So then can you advance the slide, or do I have any rights to be able to do that? Oh, perfect. Okay. Great, great, great. As you all can imagine, cancer significantly impacts the health and well-being of all afflicted patients, and AYAs in particular struggle with no longer being children, but not yet being full-fledged adults. So this can lead to unique physical, mental, and psychosocial needs. When compared to their pediatric counterparts, AYAs have more severe toxicity from the same treatment regimens and overall report worse health-related quality of life measures. On the other hand, AYAs are a very tech-savvy population and are already immersed within the internet, mobile devices, and sometimes wearable technology. Wearable devices themselves offer a method to unobtrusively collect and transmit near real-time patient-generated health data, but have not been extensively studied in those undergoing active treatment. Perfect. The main question we strive to answer is if we can use wearable devices to detect overall health or overall wellness in this population, which in turn can tailor how we treat patients. While there are a variety of tools that attempt to measure wellness, the PROMIS program uses recent advances in qualitative, cognitive, and health survey research to measure patient-reported outcomes that have a major impact on quality of life across a variety of chronic diseases. There is some data to suggest that AYAs with cancer will use wearable technology, which in turn can benefit their physical activity or quality of life measures, but comparison of activity monitoring to intermittent measures of wellness has not been extensively studied in those undergoing active treatment. Through our collaboration with the BJC Informatics team and clinical providers at St. Louis Children's and Siteman, we will be well poised to test this fundamental question and plan to do so through an EPIC interface. So our project plans to recruit AYA patients undergoing active treatment for a 90-day study in which we'll use either an Apple Watch Series 6 or Fitbit Charge 4, depending on previously owned compatible smartphones. Through utilization of the MyChart application and pairing into EPIC, we'll evaluate the relationship between step counts and PROMIS questionnaire responses. Our exploratory objectives include determining how reliably the devices are worn, the relationship between advanced physiologic measures like heart rate to clinical events such as hospitalizations, and lastly, if performed, the relationship between a 1-lead EKG generated by the Apple Watch to a standardized 12-lead EKGs otherwise done for routine clinical care. We can get to the last slide, perfect. This big idea is truly a marriage of efforts between clinicians who closely work with AYA cancer patients, and in particular my co-PI, Dr. Spraker from Radiation Oncology, who has the background and involving expertise in digital health. We'll be heavily supported by an informatics specialist, Dr. Taylor, who will further assist in implementing a workflow through Epic, and Ed Seberg, who has the expertise in wearable devices and the data which we plan to extract. It's an exciting time, and I very much thank you for the opportunity to present our project and for jumping through some of the technical issues to get started. Perfect.
Thank you, Amy. Well, we are starting to bring our judges from unmute and onto camera. So judges, are you able to speak and come off of mute?
I have to ask them to do those things, so I think they have to do something in response. It won't let me just unmute them.
Looks like Ebony is able to be off mute and on camera. Ebony, can you say something so we can make sure
Yes, can you hear me?
yes, thank you. Looks like
Excellent.
Clay as well.
I'm here.
All right, wonderful. Well, let's go ahead and get the questions started. So judges, please, if one of you wants to get your questions started, we'll start the cadence there.
I can start.
Maybe.
Thomas?
Yeah. Hey, so how are you going to determine that there is a some sort of correlation association between the step counts and the promise measures? I understand that you're going to record using a wearable device, and you're also going to get the PROs. But what is the mechanism that you're going to do some sort of, at the very least, association between these?
Yeah, so I mean, the goal is to record promise results about every 2 weeks within that 90-day study period. And then we're hoping that we can get like a generalized T-score to the promise results and see if what the correlation is, obviously, to step counts or physical activity. It's exploratory in nature, so I don't have any like set definitions right now, and I can let Matt jump in as well. I think he's unmuted. But really to just kind of see what we're able to collect and kind of move forward with just as a pilot study right now.
Yeah, I would agree with that. One thing I would just add is that I think the way that people are analyzing step counts right now and relating them to other measures is variable, variable across the literature. So I think one method that is one that we would try to use is you can break people up based on their T-score into decile groups, and then you could do quantiles for the step counts. That's been one way that people have done that, where they've kind of broken mean step count per day over a period into a quantile.
Michael, I believe you had a question.
I do, yes. Can you hear me?
We can, thank you.
Great. Amy, thank you. Very nice presentation. Are these promise measures calibrated and validated in this population you'll be including?
Yeah, so there's pediatric promise measures and adult promise measures. So I think within the age group that we are looking at, they've been validated and are verified for what we're looking at. I'm using abbreviated questionnaires, so I'm trying to avoid burnout between between our participants over time. So it's going to be just pulling up right now, the global health, which is just a 10 questionnaire based system, and then the pediatric global health will be for patients aged 15 to 17 is the health 7+2. And that covers a decent amount of components that go into quality of life measures.
Thank you.
Mm-hmm.
So Amy, thank you for a really nice presentation. I know that this is exploratory, but just thinking ahead a little bit, if you are a clinician caring for these patients, how do you use this information? How does it change the way we care for them?
Yeah, and that's ultimately what I want, right? So what I'm hoping to detect is does a change in step counts, if these patients are reliably wearing them, ultimately point to different symptoms? Are they faring worse at home? Are we being able to pull up some physiologic data, which is part of the exploratory aims, where we're seeing heart rate variability, which is maybe leading to a febrile neutropenia episode that I can detect in advance of them actually presenting to the hospital with it? So really it's, can we intervene earlier? Can we keep a pulse, no pun intended, but a pulse on our patients from afar to truly understand what they're going through from a symptom standpoint, and then from, a clinical severity as far as acute complications during their cancer period? That helps.
Can I add one quick thing just to that answer? So that's like one major category of things that people are doing with these devices. This is a really new space, so I think people haven't figured out exactly where we use these yet, but since we're ambulatory, sort of outpatient monitoring of patients to prevent events is a big one. The other major one is actually, we think that the early evidence would suggest that it's actually a better marker of physical function than current things that we use like ECOG or things like that, especially in adults. So the idea would be that if you have a better idea of someone's function or their functional reserve, you might be able to pick them out as being a good candidate for dose escalated therapy or therapeutic escalated therapy, and treat them better, with more aggressive treatment if they're more fit. Or if there's somebody who appears quite fit in your clinic, but your physiologic data would argue that they don't have as much reserve, you might kind of go away from a treatment like that and avoid something that might have more harm than benefit in a patient with less reserve. So that's kind of sort of risk stratifying people up front is another major area that this could be helpful as well.
Thank you, Matt, for that clarification. We are at 5 minutes of that Q&A. I know it does go quite quick. So let's move on to the next team and our transition. And as we said earlier, we will start muting and unmuting the next team. And we have 1 minute. As we are, as we are transitioning, let me share the results of that poll from our audience. All right. I hope everyone was able to see those results. I'm going to stop sharing as we prepare for our next team to join us. And again, thank you all so much for your patience as we figure out technology.
Yes.
Okay. So Chet, I believe you are up.
All right, good afternoon. I'm Chet Hamill. I'm a hepatobiliary and pancreas surgery in the Department of Surgery at Washington University. I'd like to thank the Healthcare Innovation Lab for giving us the opportunity to present our proposal today. So postoperative pulmonary complications are a significant burden affecting 1 out of every 8 patients that undergoes major abdominal surgery. In patients that experience a postoperative pulmonary complication, there's a 10-fold increased risk of mortality after surgery. Hospital cost in these patients is increased on average by $30,000. On average, length of stay in patients that experience a postoperative pulmonary complication is extended by 8 days. And finally, these patients are at double the risk of readmission after surgery. Fortunately, there's a very simple solution to this problem, the ubiquitous incentive spirometer, or IS. This is a simple device, it's inexpensive, and it's designed to increase pulmonary function. So the Barnes-Jewish system purchases and distributes 60,000 of these devices every year. Of course, if it was really this simple, I wouldn't be here talking to you today. The American Association for Respiratory Care states in their guidelines, I'll directly quote, "Due to the lack of evidence, incentive spirometry is not recommended for post-op prophylaxis in patients." 5 meta-analyses have all concluded that all the studies in incentive spirometry have significant methodological flaws. And the primary one is compliance. Only 16% of these studies comment on compliance. And in the studies that do address it, it's patient reported. So our proposal is to use a FDA-approved digital incentive spirometry that allows us to remotely monitor patient compliance. Our protocol, which has been submitted for institutional review, involves an initial randomization to no intervention, preoperative standard IS, or postoperative digital IS. And then a second randomization is performed after surgery to postoperative standard IS or postoperative digital IS. In patients that are getting a postoperative standard IS, we're going to put an accelerometer in the device to get a rough measurement of compliance. I'm joined in this project by Dr. Chen-Yang Liu, who's a professor in the Department of Computer Sciences and Engineering at Washington University, and Peggy Watts, who's a manager in the Department of Respiratory Care Services at Barnes-Jewish Hospital, both of whom have been instrumental in designing our protocol and will be invaluable in disseminating and implementing any changes in clinical care based on the findings. Thanks for your attention, and I welcome any questions.
Well, Chet, thank you so much for that wonderful presentation. We are unmuting our judges, and it looks like Dr. Avedon has his hand raised. So could you please start us off with the Q&A session?
Sure. Chet, thank you very much. A very interesting presentation. Why do you think that the people who are compliant won't simply be the ones who are at low risk for complications, and that you'll have a very strong association between non-compliance and complications?
Well, I think if that happens, so one thing I didn't get into due to the time constraints is that we are including text message encouragement in the patients with the digital IS. So if they're not performing the IS, we're going to encourage them to do it. I think the goal of this study is to determine if it really is compliance that determines whether IS is effective or if IS is just not effective at all.
Chet, can you hear me?
Yep.
Good. John Lynch, boy, this hits the sweet spot for me. You can imagine how many times I run around in rounds waving an incentive spirometer for patients. That technology allows both to document both the inspiratory effort and the expiratory effort.
That's correct.
I think we've been taught over the years that it's the inspiratory effort that is maybe most important in the pulmonary hygiene.
Yeah, it allows you to document both. The device actually allows you to perform pulmonary function tests. So we're going to use the device to perform pulmonary function tests on all the patients at 4 time points as our outcome measure.
And will the patients be coached? Will they receive some standardized coaching in the use of this particular device?
Yes. So
low inspiratory effort is also thought to be important.
Yeah, the device actually has an app on your phone that coaches you through it and encourages you to use it appropriately. And then each group will be coached appropriately for their device.
Thank you.
Clay, would you like to ask a question?
Did you ask me, Ali? Sorry.
Yes.
Hi, Chet. Great presentation, and obviously a big issue. Particularly if it doesn't really work. How many subjects are you going to have? A lot of branch points. How many subjects are you planning to enroll in it?
So we're doing 150 patients, so 50 in each of the first 3 groups, and we powered it for that preoperative thing. The postoperative stuff is a little more exploratory, just because we don't have good data to do a power analysis.
Got it.
Great. Any other questions from the judges?
I actually have a question. I thought that was a great presentation. I was wondering, is the ZEPHRIX system validated with the 60,000, incentive spirometers that we use at Barnes? Because I was wondering if there's a difference. Is it actually because of the technology? Is it the texting? What part of it is actually making a difference?
So the device is actually FDA approved for pulmonary function tests. So presumably in their, FDA approval, but I don't know that anybody's directly validated it with our incentive spirometers. And truthfully, I think it would be a little difficult. I don't know how you could do that.
Well, and I wonder about it just practically, the cost, I'm sure, of having the system that you have versus the 60,000 that Barnes uses, I'm sure it's quite different.
Yeah, I mean, the plastic ones we hand out are really inexpensive. They're like $2. And obviously these are more they're under $100, but still significantly more expensive. But one question I want to answer is, do we even need to be giving out the $2 ones? And then if the $2 ones, if it is effective, are the $2 ones effective or not because of compliance? So, there's multiple questions that I think that are ripe for answering with this study.
Thomas, I know your hand was raised. We have about 30 seconds.
So how, Chet, great presentation. How early are you starting the recruitment for participation? And also, once the values are uploaded, how often do you monitor those going forward?
So we're monitoring them in real time so we can text them when they're not using it. So basically, if they haven't used it, in a day, then we're going to be texting them. So we're kind of monitoring them in real time. This all came about because we started a preoperative rehabilitation program and we're going to use IS. And then we looked in the data and we realized it wasn't there. So we're trying to catch them about 3 to 4 weeks prior to surgery to give them a good time to, improve their pulmonary function.
Yeah, so just to follow up on that, so you're only looking at adherence to the usage, not actually the scores they have from the PFT.
No, we are looking at outcomes. The devices will give us PFTs. So we're looking at changes in PFTs in all the groups too.
Okay. Thank you.
Thank you all. We are at time. Again, I know that goes very quickly. So for our 1 minute transition time frame, I'll share our results of this poll. And for the score of clinical applicability for presentation number 2, 69% of the audience voted this as high, 21% voted medium, while 10% voted low. For the score of feasibility of presentation number 2, 46% presented high, 41% presented medium, and 13% voted low. And finally, for the third score of team composition, we have 54% who voted it high, 36% who voted medium, and 10% who voted low. So again, the magic of technology, we are unmuting our next presentation, which is Mackenzie. If you can let us know if you can speak.
Yeah, can you hear me?
Perfect, we can hear you and see you.
Excellent.
All right, so let's go ahead without further ado and advance to your first slide.
Perfect. Hello, my name is Matt Cofford. I'm one of the clinical informatics fellows here at WashU. Today, I would like to talk to you about our clinical decision support environment and how we can use computational approaches to increase the reliability of these systems. I find sailing on the ocean to be a useful analogy for the delivery of healthcare. The hazards are often unpredictable and hidden. The domain knowledge required is vast, and the task is inherently dangerous. At WashU, we have some of the foremost experts in medicine whose knowledge we have leveraged to develop warnings to help navigate through a sea of drug-drug interactions, dosing issues, and other common errors. We have a governance structure in place for the management of these alerts, and we spend hours with clinical and technical experts designing these alerts to fire in just the right way to make a maximum impact on safety while not causing interruptions to workflows if none are needed. We discuss them and test them, then we toss out the alerts into the clinical environment and we hope they keep doing their job. I like to think of these alerts as buoys, marking hazards that might have otherwise been underappreciated. Right now we have thousands of buoys alerting clinicians over 1 million times per month. However, just as a storm can cause buoys to drift or sink, changes to drug codes or updates to the EHR can cause alerts to fire when they should not, or stop firing altogether. If we are lucky, clinicians will notify us when alerts are not behaving as they should, but alerts that stop firing are much harder to find. This is essentially a 19th century solution to dealing with hazards, and there are too many alerts to inspect by hand. Prior work has demonstrated that CDS malfunctions are common, but the literature lacks a systematic description of CDS malfunctions in a health system. What we need is a 21st century solution, a smarter buoy that can alert us when it starts to drift or sink so that we can inspect and fix it. The system already produces data on alert firing rates. We can use these data to look for anomalies in the rates of firing that could represent malfunction. This will allow us to narrow our search for malfunctioning alerts to those with the highest probability of having issues. Some work by Wright et al. Has shown this is possible, but they reported results only on a convenient sample of 4 malfunctioning alerts and used 6 different statistical models to do it. We will produce both a systematic description of the malfunctions present in our system, as well as a report of the performance of a statistical model developed to identify malfunctioning alerts, We already have the experience to create the best alerts, the governance structure to manage them. We have high quality data about how and when they are working. What we need to develop is a tool to monitor these data at scale to ensure they're working as intended. We've assembled a team with diverse backgrounds in clinical informatics, medicine, pharmacy, statistics, machine learning, and quality improvement to address this task. Thank you for the opportunity to present today. Happy to answer questions.
Mac, thank you so much. Judges, you should already be unmuted. So if you could raise your hand if you have a question to get us started for the Q&A.
I'll start.
Thank you, Thomas.
So what is the range of malfunctions you're looking at, Mac, just to understand the range of problems you're looking at, because this is a very, very broad area. If you're looking at CDS alerts.
Yeah, absolutely. So we're interested in both BPA and medication alerts. And the idea is that sort of unintentional changes, either updates to the drug knowledge bank, which happens monthly, or updates to Epic, can cause unintentional changes that we should see in it with a change in the firing rate. I can already, like, just looking back through tickets, I found a few examples in the past where we changed something unintentionally, like a lab code, and then firing for it drops to 0, like a month or 2 afterwards. The literature on this kind of shows that it won't always just go down to 0 because maybe only one medication changed or only at one place. But you can, if you use an anomaly detection model, you can at least tell that, hey, something funky is going on there. Maybe we should look at it. So instead of having 1,000 alerts that you're trying to manage, you've identified a subpopulation that's firing differently than it was before, and you can take a look at those. So it makes it a much more manageable task.
And Thomas, we'd be looking at not just alerts that are no longer firing, although those are the hardest to find.
Yes.
But alerts that are start firing more, but maybe not so much more that we're being alerted to it, or firing in different patterns, like in different places than we would have expected, because there's been a change in how they're firing. So potentially all of those would be subject to these models.
Thank you.
Great, thank you. Ebony, I know that you're having trouble with the hand raise function. Did you have a question?
Nope, I'm good.
All right. Any other judges? Questions for this team?
Can I ask another question?
Please.
You just did.
So this is obviously a very interesting area, and it has implications. But are some anomalies more interesting than the others? So, for example, medication anomalies are sort of there's so many factors that play into why there's anomalies. So, for example, during COVID, or how often do you have to update these models to be, if you're looking at medications as a space, right? Like medication alerts as a space, but how often do you have to, how robust are these models, and how often do you have to update them?
Yeah, so that's an area of kind of active research. No one's published on an operationalized version of these. I know it exists at 2 other institutions because we've talked with Adam Wright, who's been active in this space, and he's operationalized it at Partners and Vanderbilt. but no one's published on it and they're not collecting statistics. I mean, COVID's kind of a once in a generation thing. Like most things, you'll probably, I think we'll have to normalize for the number of patients admitted, and I think we'll have to normalize for season a bit to kind of smooth things out. But I think that'll be interesting to look at.
Yeah, so, but, I was getting to Adams models essentially, but they're fairly rudimentary models, right? Like they're not sophisticated enough to detect, minute changes or changes that are, like rare events or events that are caused sort of temporally in a temporal fashion, right? Like, so these models are pretty, I know it's not been published, but it's pretty rudimentary, how these models have been developed.
Yeah, and I think we have an opportunity to expand on that as well. What I'd really like to do is kind of take his models, do a first pass, find as many malfunctioning alerts in our pass as we possibly can, and then kind of apply a machine learning approach to hopefully generate like an ensemble of models is where I think this will go, to sort of improve the sensitivity and specificity going forward. But the first step is to generate that comprehensive history of all the previous malfunctioning alerts, mix in some functioning alerts at like a 50-50 ratio, and then use that as sort of our lab to develop the best possible model, and then apply that person report on it.
Yeah, and Thomas don't disagree. Adams models are right now fairly simplistic. They're still well ahead of anything else that anybody else does.
Yeah,
So,
I agree. I wasn't trying to be, trying to.
Yeah, you're absolutely right.
I think there's an opportunity. To kind of progress there that I think that we find very exciting.
And with that, I'm going to encourage you all to have an offline discussion if you want to further that. We are at the 5 minutes, so we'll start our transition of the 1 minute transition to our next team. So we will start to get Kevin ready for his presentation. In the meantime, I'll share our results from the poll. We had about a 40% participation rate, so please do encourage you to participate in these polls. It's very helpful for us as we're assessing each of the teams. For the first score of clinical applicability, we have 35% voting high, 35% voting medium, with 29% voting low. With the score of feasibility, we have 21% with a score of high, 35% with a score of medium, 44% of a score of low. And for a third score of team composition, we have 35% score of high, 38% of you thought medium, and finally 26% in the low category. So thank you all for participating in that poll. I'll stop sharing the results. And Kevin, are you able to come off of mute?
I am.
Wonderful. We can hear you and see you. So if you're ready, I'll go ahead and advance the next slide and you can get started.
On behalf of my team members, I want to thank the organizers for allowing us to pitch our idea on the use of wearable sensors as a strategy to improve outcomes in liver transplant candidates. And you can advance the slide. Of the over 13,000 people added to the liver transplant waiting list in 2019 and 2020, 15 to 20% were removed from the list because they became too sick, became medically ineligible, or they died. The conventional wisdom in transplant hepatology is that physical decline, or what's commonly called frailty, is a driving factor for waitlist removal. As much as patient attrition is an issue for patients, it's also a metric by which our program is judged. Next slide. We believe that frailty is an issue for our liver transplant program. Frailty is associated with age, and over the past 15 years, the mean age of patients referred to our liver transplant program has increased from 51 to 58 years. This cohort frequently have a greater number of cardiometabolic comorbidities as the indications for transplant shift from viral hepatitis to non-alcoholic fatty liver disease. We believe these trends are relevant to our transplant center. Transplant programs are categorized on a 5-point rating system based on rates of waitlist deaths. As indicated in the density plot, our program, denoted by that red circle, is the lowest in the lowest tier, indicating the higher waitlist mortality than other transplant centers including those with similar volumes of transplant. This rating system is one of 3 metrics accessible by the public to compare transplant programs. Our hypothesis is that wearable sensors can be successfully deployed to at-risk liver transplant candidates to assess physical conditioning, motivate health-promoting behaviors, and impact tangible health outcomes. Though we believe the strength of our proposal lies in the people and processes detailed in our written proposal, we also hold that the information platform is central to our success. We propose to use a gene-active device, a wrist-worn triaxial accelerometer with the ability to sense near skin temperatures and luminosity. The device can record up to 1 month on a single charge, has a price point that is scalable, and can be analyzed using open access software platform. My team includes the members of the hepatology section in the Division of Gastroenterology and Magella Doyle, the surgical director of liver transplant. These individuals will identify subjects, design interventions, and perform analytics on the collected data as a group effort. We will be assisted by Jessica Wagner and Tanya Barron, BJH members who are quality coordinators in the transplant center. Mrs. Wagner is an EPIC level 4 reporter and will help us merge data from the EHR with that collected by the sensors. She also works closely with EPIC level 5 reporters who have access to the Clarity database. We believe that this project will allow the members of the Washington University Liver Transplant Program and the BJH Transplant Center to work collaboratively to advance a common goal of improving the health of our liver transplant candidates. Thank you.
Thank you, Kevin. Judges, you now have 5 minutes to ask your questions, and if you could raise your hand to start the first question. John, would you please start us off?
Kevin, interesting problem for sure, which probably affects many transplant populations. But what are the other interventions as well as the wearable solution that you're talking about? What are the things that go along in terms of coaching or feedback to the patients that would encourage them to get up and move around?
The proposal that I couldn't get into because of time is, at least for this grant, as a 2-part one. The first part is simply to make sure that we can provide the sensors to the patients and then get the data back from them and then send back new sensors to them with a new charge so that we can complete the cycle of data collection. In the second phase, our idea would be to have at-risk patients identified through something called a liver frailty index, which is a validated form of assessing frailty. Have them see a physical therapist as initial evaluation and get a list of activities that they can do at home, and then we can monitor them with the sensors as they come back. And then we would then close that circle to say, how did they do with the physical therapist? How much did they advance? Now, I will say that the current state of the art in hepatology is not established for this. Just this week, there was a publication of using a smartphone app to motivate behavior. So this is sort of the new frontier, and it really isn't well worked out. We do not have the abilities now to create an app de novo. That would be something that, if it's validated, we could do in the future or work towards in the future. But that also presupposes that patients have access to smartphones. And one of the things that's true about liver transplant patients is they tend to be marginalized. So simply by giving them an electronic device and doing this sort of analog in terms of the information you're giving them, it at least gives us a foothold into this process.
Thank you.
Thank you very much. Judges, any other questions? I don't see any hands raised.
I have one, and this is probably just my ignorance of liver transplant. You said that the quality of the program is judged based on the frailty score. And so I guess I'm wondering, would the frailty score be used to figure out who's eligible? Does it try to increase the likelihood that somebody is eligible by increasing their activity? How does it actually end up being used?
What we're judged on is our rate of waitlist death. We submit what are called program reports, and they cover a 2-year period. And if we have someone die on the wait list during that period of reporting, it is used in a model that's based upon risk factors to rank our program compared to other programs. You can see one obvious problem with that. If you know that you're going to be ranked compared to other programs, you might take less risk on patients, right? And one of the things that you saw on the density plots, I think people picked up, is that there seemed to be a shift so that more programs with bigger volume tend to focus in lower tiers and smaller programs in higher tiers. And that discussion is a whole other discussion about why that may be the case. So rather than engage in that polemic, what we simply want to do, because we do take risks on lots of patients, is to ask, can we improve our waitlist mortality because we know we're going to list frail patients, but by keeping them in better shape than they are when we first meet them.
Thank you, Kevin. Judges, we have about a minute left for questions for Kevin and his team.
Can I ask a quick question about, so just to be clear, this is an exploratory study at this point, right? Like you're trying to see if you can actually make this work. My question is, how do you connect the sensor data to the frailty index? Eventually, how would you do that?
I think what we would use is the liver frailty index to identify at-risk patients, and then the intervention would be connected to the sensor data. But I think that there's an interesting interplay here. On the one hand, sensors are seen as monitoring the intervention, whatever that is. But one wonders if by giving this to a patient, you are then also motivating behavior. By giving them a token or something that says, look, we are giving you something of value to use, that itself serves as a reminder. And that could be true of Chet's presentation or my presentation or some of these other ones. In fact, whether or not that aspect of these wearables to help motivate behavior is just another component that has been less well explored in this sea of wearable data.
Thank you, Kevin. We are right at time. So with that, thank you so much for your presentation. We will start to transition, our 1 minute transition to our next team. Rachita, we are taking you off of mute. And in the interim, I'll share our results for that presentation. We had a score for clinical applicability, a 55% scoring with a high rating, 24% medium, 21% low. For the score of feasibility, 26% rated it as high, 50% rated it as medium, 24% rated it as low, and finally for the score of team composition, 37% rated this as high, 39% rated as medium, and 24% rated as low. So Rachita, are you able to come off of mute and can we hear you?
Can you hear me?
Yes. Wonderful. Well, Rachita, if you're ready, we will go ahead and advance to your first slide and you can go ahead and start.
Okay, fantastic. Hi, I'm Dr. Rachita Navarra. I'm a cardiologist and bioengineer and very excited to share our collaboration between the Division of Cardiology and the Institute of Informatics on novel technology to start antiarrhythmic medications safely at home. Next slide. The current standard of care needs to change. Imagine having an abnormal heart rhythm. There are effective antiarrhythmic pills that can help, but just to start taking one of these oral pills, you need to be hospitalized for 3 or more days just for monitoring. This has been the standard since these meds were approved by the FDA in the 1990s. Of course, there is never a convenient time to be stuck in the hospital, especially not when even sick, and let alone during a global pandemic. From a BJC standpoint, this leads to an overuse of hospital resources. These admissions generate low revenue, and they affect readmission metrics when patients need to be readmitted just to adjust their dose. From a WashU standpoint, this commits limited clinical time to low complexity care with minimal educational opportunity. Next slide. This leads to a rapidly growing problem. AFib affects 34 million people worldwide, and that is rising rapidly as our population ages. AFib caused $26 billion in the US alone, and the majority of these costs are on hospitalizations. There are 75,000 hospitalizations each year just to start heart medications, and in Barnes and WashU alone, there are 5,000 hospitalizations under the diagnosis of AFib each year. Each drug load hospitalization costs $17,000 based on Barnes Jewish data. And obviously this is inadequate from a cost, convenience, and safety standpoint, as patients can have side effects from these medications even beyond that 3-day period that they're in the hospital. Next slide. Our solution is the first take-home kit combining FDA-approved hardware and novel EKG software. This software automates a measurement of the specific feature we track in the hospital called QTC. Our specific aims for this one-year proposal are based on our recent NIH STTR proposal, with aim 1 being to advance our current EKG automation software into an AI-trained algorithm trained on our rich data set of patients admitted here for starting these drugs at Barnes-Jewish. Aim 2 is validating the algorithm's ability to actually recommend a dose that a doctor would approve. This proposal has formal support from our BJH CMO, as well as the Director of Operations, who have said that this will optimize patient throughput and improve readmission metrics, thereby providing a substantive benefit to hospitals and patients. We are a collaboration between cardiology and the Institute of Informatics across WashU and BJC. And we're supported by an expert advisory board, including the father of our medical specialty and the president of our International Heart Rhythm Society. Fortunately, NIH preliminary feedback has agreed that we are the team to bring this proposal to fruition and thereby improve the outcomes of our patients by expanding access to these important medications. Thank you so much.
Thank you so much. With that, we'll transition to our Q&A session. So judges, if you do have questions, if you could please raise your hand. And do we have anyone who would like to start? Clay, please start us off.
Yes, in the, do you have data on how often patients hospitalized for medication initiation have problems that require correction? I'm just wondering how many people you have to see to prevent one event.
Yeah, so really the key with our take-home kit is a wearable defibrillator that will be provided to all of these patients. That is key to the safety. So from our inpatient data, for instance, we have not had any patient require a shock or a defibrillation due to heart rhythm side effects. But even in the outpatient setting, we would be trusting this wearable defibrillator vest, which has been FDA approved for much sicker patients, those with heart failure, those who had an implanted defibrillator that has been temporarily taken out, et cetera. So that's the safety data from our hospital. And really the reason these patients are monitored in the hospital is to closely track their EKGs. And so through that EKG monitoring, we avoid any of those defibrillation or other adverse events.
Wonderful. Thank you. Judges, any further questions?
Yeah, I want to, sorry, Allie, I just want to peel it back a little bit further. I was really asking the feasibility of detecting events, because if the population under study is at low statistical likelihood of having events, it'll be hard to see if there's a signal. So I don't know what the a priori event rates are.
Great point. Yes. So in our specific software implementation, we are not focusing on just the events of a patient actually needing a shock, as you point out. We're tracking specifically the interval that we measure on these paper EKGs with calipers called the QTC. And that measurement has very specific thresholds based on these drug labels, where if a QTC rises above a certain millisecond threshold, then the drug is recommended to be decreased or stopped. So we're really basing this on quantitative measures of patients' EKGs from when they were hospitalized to start these medications in order to really provide precise measurement capabilities of the software. So as you point out, we don't have a volume of patients who've had adverse events, fortunately, but that's why we're specifically tracking this quantitative interval that we currently measure just with calipers in the hospital.
This is Mike Rich. Can you hear me? Can I add to that?
Yeah. Hey, Mike.
Yeah, great. So, to further respond to that question, prolongation of QTC is quite common with these medications and fairly unpredictable. We can't tell in advance who's likely to have a prolongation of the QT, and that's why we have to hospitalize all of these patients for the relatively small percentage that is going to have a significant prolongation of the QT that might lead to torsade de pointe ventricular tachycardia or some other adverse outcome. This technology will allow us to very precisely, through the use of AI, to develop our algorithm to determine who is having a prolongation of the QT and therefore might require a dosage adjustment or perhaps an outpatient visit for further management. And so it will enable us to carefully monitor all of these patients who normally would require hospitalization for this type of monitoring.
Thank you.
Michael, you had a question?
Rich just answered my question. Thank you.
Oh, well, Mike and Michael, thank you for thinking ahead. Judges, any further questions? We do have about 50 seconds left.
I'll take the bait. So you're going to train, just to clarify on the mechanism, you're going to train based on hospitalized data to make predictions on sort of free living at home conditions, right? Like that's the approach. Do you think those two that actually will translate?
Yeah, that's a fair question. And really the main metric, as we mentioned, is this specific objective interval on the patient's EKG. So we don't anticipate, of course, we'll be constantly tracking the training data set, but we don't anticipate environmental changes in that regard. It's really an objective interval based on how the patient's heart rhythm and electrical conduction is responding to the medication, which, as Dr. Rich pointed out, is unpredictable.
Thank you. We are right at 5 minutes. So judges and panelists, thank you so much for your presentation. With that, we will advance to our 1-minute transition, and Kate will be bringing you off of mute for your upcoming presentation. In the meantime, we'd like to share the results of our attendee poll. For the score of clinical applicability, 72% voted this as high, 22% voted this as medium, and 7% voted this as low. For feasibility, 46% of attendees voted this as high, 41% voted at medium, 13% voted at low. And finally, for the team composition, 65% voted at high, 28% at medium, and 7% at low. So thank you all for your participation in that attendee poll. And Kate, are you able to come off of mute?
I should be off mute. Can you hear me?
We can hear you and see you. Thank you so much. If you're ready, we'll advance you to your first slide.
I'm ready. All right. I'm Dr. Catherine Lindley. I'm a cardiologist and a specialist in cardio obstetrics, and I'm happy to present our project on behalf of my team. Next slide. Hypertension complicates 15% of US pregnancies and is rising. It's responsible for 44% of deaths in the first week postpartum and is the leading cause of postpartum hospital readmissions. An analysis of our own hospital identified that 37% of women with hypertensive disorders of pregnancy had at least one rehospitalization after delivery. Improving care of this high-risk group aligns with the BJC priorities to provide efficient, accessible, patient-centered care. Next slide. Only about 64% of the most deprived women delivering at our medical center receive any postpartum care. Those least likely to receive care also most likely to have underlying risk factors for postpartum cardiovascular complications. Next slide. In August 2020, we launched the My Heart Postpartum Hypertension Clinic to provide patient-centered multidisciplinary care to women with hypertension in pregnancy. On analysis of the primary reasons why patients reported they were unable to attend their clinic appointments, inadequate social support, including childcare and transportation, were the leading contributors. We also identified that 93% of patients were overweight or obese, highlighting an unmet need for focused nutrition counseling. Next slide. Our big idea is to simplify comprehensive postpartum care in high-risk patients through the expansion of My Heart to a virtual platform with integration of nurse-based nutrition counseling. We will examine healthcare utilization, including clinic visits and hospital readmission rates for women with hypertensive diseases before and after the institution of the virtual My Heart Clinic. We anticipate that expert intensive blood pressure management in the early postpartum period and heart failure symptom screening will lead to reduced need for hospitalization. We'll also assess the impact of virtual nurse-based nutrition counseling on quality of diet in women with hypertensive disorders of pregnancy. And finally, we'll determine the cost effectiveness of virtual My Heart Clinic and calculate the costs and/or savings from the perspectives of the payer and the healthcare system. As a cardio obstetrician with expertise in the management of cardiovascular disease in pregnancy, I'll be providing the patient care for this proposal. This research builds off of my prior work centered on the cardiovascular sequelae of preeclampsia. I'll be collaborating with an outstanding team. Dr. Sarah Farabi is a lifestyle intervention expert who will provide the training and expertise required to institute nurse-based nutrition counseling. Dr. Nandini Ragaraman is an MFM who has championed the MyHeart program within the OBGYN division for the past year. And Dr. Karen Joint-Maddox is a health policy expert nationally recognized for her expertise in bundled payments and sociodemographic disparities, and she will be performing the financial analysis of the MyHeart program. I'm happy to take any questions you may have.
Thank you so much. Judges, if you could please raise your hand to start off the Q&A. And Michael, please start us off.
Catherine, thank you. Very interesting and clearly an important problem. From a scientific standpoint, why have you chosen to do a before and after study? Why not randomize these people postpartum to either attend the existing physical clinic or your innovative virtual clinic?
Well, that's a good question. I mean, that certainly would be another way to perform the study. We've chosen to do a pre-post analysis where we have developed already a database from the whole year of 2019, and we'll be comparing to a comparable seasonal time period during that year, where we've extracted all the financial data and clinical follow-up data during that time period, so that we'll be able to sort of compare all comers during that same time period.
Thank you. I know, Thomas, you had maybe a question. We're bringing you off mute.
No, I did not.
Okay.
Muted.
So this is Deborah. I have a question, but I don't know how to raise my hand on this. So
That's okay. Go right ahead, Deb.
can you, do you have any concerns that this population will have challenges with access to a digital platform, internet, technology?
So that's a really good question, and we think that that's going to be unlikely. There have been other recent studies performed in similar population. There was recently a study performed looking at Medicaid patients being studied with a breastfeeding app, and we know from that study that the majority of women who are of this population who are on Medicaid do have smartphones already, which they will be able to use for the Zoom platform.
Clay, did you have a question? Or was that just any other questions from our judges?
I have one. So, we know that these patients are at significant risk for future cardiovascular disease. Is there anything in the platform that helps to bridge them back into primary care?
So that's a great question. So we do, during the course of the 12-week follow-up, we extensively counsel them on their long-term risk for cardiovascular disease and provide comprehensive cardiometabolic screening, including blood pressure management, diabetes screening, and cholesterol screening. We then do assess each patient with regards to whether or not they have a primary care provider, and if not, then we do provide referrals back to either the residence clinic or other providers within the Washington University system who are currently accepting patients. And then all patients at the end of the 12 weeks who have ongoing need for hypertension management or other cardiometabolic risk factors are then funneled into long-term care within my cardiovascular prevention clinic.
Have a little over a minute left. Judges, any other questions for Kate and the team? Okay. Well, with that, Kate, thank you so much for your presentation. We'll go ahead and start to transition to our next presentation, and I'll end our polling. So as you can see from the results for Team 6, 49% voted high for clinical applicability, 33% medium, and 19% low. For feasibility, 40% of attendees voted this as high, 33% at medium, and 28% at low. And finally, for team composition, 37% voted high, 35% at medium, and 28% at low. So again, thank you so much for your participation in that attendee poll. Up next, Michael, you should be coming off of mute. Can you let us know?
Yes, hi.
We can hear you and see you. So with that, I'll stop sharing the polling results. And if you're ready, we'll go ahead and advance you to your first slide.
Sounds great. Thank you. My name is Dr. Mike Montana. I'm an anesthesiologist at St. Louis Children's Hospital. My team's long-term goal is to develop a warning system to predict hypoxemia, a low oxygen level that may be life-threatening to children having surgery. Hypoxemia, otherwise known as low oxygen in the bloodstream, can cause irreversible damage to the heart and brain in 5 to 10 minutes. In the upper right of the screen is a published national description of several children who died or suffered permanent neurologic damage, likely from hypoxemia, during or after routine surgery to remove their tonsils. Not all these deaths occurred in the operating room, however, uses cases to illustrate the worst case outcome that can result from hypoxemia. At St. Louis Children's Hospital, we conduct approximately 16,000 anesthetics a year. Just at our hospital alone, there are on average 2 instances of hypoxemia lasting at least 10 minutes every week, or about 100 times a year. These numbers come from an IRB-approved retrospective study that my team conducted of over 70,000 anesthetics performed at St. Louis Children's Hospital from 2014 to 2018. First, we excluded patients with a diagnosis of congenital heart disease that might cause hypoxemia at baseline. Then we identified nearly 500 cases of hypoxemia, which importantly we defined as an oxygen saturation of 90% or less, occurring consecutively for greater than 10 minutes. This is a long time. Using these cases, we retrospectively developed a deep learning model using 9 static preoperative characteristics and 18-minute resolution intraoperative dynamic fixtures to predict hypoxemia up to 5 minutes before it happened. Our model outperformed state-of-the-art shallow models. Currently, anesthesiologists receive alarms as patient conditions are deteriorating, similar to a structure fire. It'd be much better to have us respond to a smoke alarm before the building is on fire. And the big question we ask is whether we can use our model to predict hypoxemia in a real-world setting. We aim to accomplish this by first integrating our model into the Epic EMR to trigger a silent alert that will fire up to 5 minutes before an event is expected. We plan to do this prospectively with 1 year's worth of cases at Children's Hospital. And then we'll examine the cases in which the alarm is fired, as well as those in which the alarm should have fired, to determine whether it in fact did. This will determine whether our model is clinically meaningful in a real-world setting. Our team includes Dr. Chen-Yang Liu, an internationally recognized expert in machine learning, and his graduate student, Eric Liu, developed the deep intraoperative alert model that we will incorporate into Epic. Also critical to the integration is Dr. Thomas Knopolil, who's an informaticist experienced in implementing novel projects in the Epic EMR environment. And as I mentioned, I'm a pediatric anesthesiologist at St. Louis Children's Hospital. I will coordinate the effort and lead the team validating the cases to make sure they're clinically meaningful. Thank you for this opportunity.
Thank you so much, Mike, and for your guest speaker.
Yes, I had a guest
and we're all wondering what your guest speaker's name is.
His name is Buster.
Well, thank you, Buster. And thank you, Mike. In all seriousness, that was a wonderful presentation. We'll start the Q&A session, but before we do get started, I just want to let everyone know that Thomas will be excusing himself from a judging position, given his interest in this team. So for the rest of our judges, are there any hands up for starting our Q&A?
So earlier we heard one of the teams talk about all of the alerts and sort of the alert fatigue and needing to know how we're responding to it. So how does adding another alert and how do you think about that fitting into what you're trying to do
Sure.
in terms of
The
being able to
difference is
answer
this
that?
alert, the critical difference is this alert predicts something that we expect to happen as opposed to something that's already happening. We actually did an alert analysis as well to see how often we thought it would go off. And we thought it would actually go off meaningfully about 2 to 5% of the time. However, the alert fatigue based on this, based on the rarity of cases, is actually pretty low. And because of how critical the event is, we didn't feel like people would be upset by that. I get alerts constantly, but if I get an alert that tells me within the next 5 minutes, somebody might be hypoxemic to the point where we'll kill brain cells, I'm going to pay attention and be interested.
Thank you. Any other questions from our judges? Michael.
Thank you, Mike. A very interesting presentation. In a few years ago, there was an article in the New England Journal of Medicine led by Mike Grocott, where they climbed up Mount Everest and showed that people's saturations dropped down into the 50% with no neurological injury.
Absolutely. So
You say that 90% will kill brain cells, but I'm not sure that that's right.
Well, I'll throw back a different question maybe and try and answer it myself. How old were those people? What physical condition were they in? And how long did they acclimatize before they reached Mount Everest? And I think the answers are not pediatric patients with a different VO2 max, much older, and about a month and a half to be able to tolerate those conditions.
So again, a follow-up, you said 2 children a week have prolonged hypoxemia.
Based on my definition.
So are we having 2 kids a week who are having neurological injury currently?
I hope not, but we're definitely having, based on our statistics, 2 children a week who are in some risk for that. I think the main thing for me is that bradycardia happens much faster within a pediatric population than it does with an adult population. And they just don't tolerate it for the same time period. If I have a child who's hypoxemic into the 40s, which happened yesterday to me, their heart slows down and then we have to start chest compressions. You don't have to do that in adults, I agree with you. But if I didn't have to start chest compressions on that patient and I had a warning system that said I wouldn't, within 5 minutes, there's a 2% to 3% chance your child will need chest compressions, I wouldn't mind that.
Sure. I think it's a very interesting idea. I just wonder if you should re-examine your threshold.
Fair enough. Yeah, we had to pick something. So we started with 90% for 10 minutes. So thank you for the thoughts. I appreciate it.
Wonderful. We have about 50 seconds left. Judges, any last questions for Mike? All right. Well, thank you, Mike, for your presentation.
Thank you.
As we do, we will start our 1-minute transition to Zach and make sure that he becomes off mute. In the meantime, oh, sorry.
It's actually going to be Jacob.
Oh, Jacob, I'm sorry.
Yeah.
Thank you, Jacob.
And I just wanted to confirm, Jacob, that you're on your own. Zach is not joining. I don't see him in the panelist list.
Yeah, that'll just be me. I know he was struggling to make it out of the operating room, so you'll just have to bear with me.
Okay, you'll do great.
Wonderful. Just before we get started, Jacob, I do want to share the results from the previous team's polling. So for our clinical applicability, we had 59% at high, 24% at medium, 17% at low. For feasibility of the project, we had 35% of our attendees rate this as high, 50% at medium, and 15% at low. And for our team composition, 43% of our attendees rated this as high, 43% at medium, and 13% at low. So with that, Jacob, if you're ready, I'll advance to your next slide.
Yeah, please. All right. Thank you. Hi, everyone. My name is Jacob Greenberg. I'm one of the PGY 6 neurosurgery residents here. I'm going to be talking about our proposal to use mobile health technology to capture the physical, functional, and psychosocial features that predict recovery after lumbar fusion surgery. Some background, low back pain is one of the most common and debilitating problems in the United States and worldwide. And because of that, lumbar spine fusion is one of the most common surgeries performed in the United States and at Barnes-Jewish Hospital. Now, as clinicians in the healthcare system, we want to improve our patients' outcome by decreasing pain interference, opioid use, and medications, while at the same time improving functional recovery. Now, we know that key influences on surgical recovery include preoperative pain characteristics, physical function, and mental health. But right now, the lack of precision tools for evaluating these key domains is limiting our ability to use this information to produce better clinical outcomes. And importantly, one key piece of information we think we're missing is information on real-time symptom dynamics. So you can see here pilot data that we've gathered for the first time in a real lumbar fusion patient using brief mobile surveys called ecological momentary assessment, where we've shown the substantial variability in key measures like pain and mobility symptoms over a 2-week period. And growing evidence in fields like psychiatry suggests that understanding key measures like symptom stability and the real-time relationship across these domains is key to producing better clinical outcomes. And importantly, we've shown in 9 pilot patients that we can gather these types of data with 90 adherence. And in past work, members of our team have also shown the feasibility and value in using passive biometric monitoring using devices like Fitbit in surgical patients. So for this study, we plan to recruit 60 lumbar fusion patients who will undergo ecological momentary assessment 5 times during the day, while we passively monitor their biometric fit. We'll then take this intensive data and plug it into our analytic platform, which we'll use to predict not only overall risk of these key recovery metrics, but also the individual domains driving that outcome. So just to give you a final example of what that will ultimately look like, take this 65-year-old lady being evaluated for first-time lumbar fusion. And our multidimensional data overall 30% risk of poor functional recovery. But moreover, her individualized risk profile tells us that it's really her pain and mood characteristics rather than say her physical function or comorbidities that are driving that risk, helping us focus on the need for intensive perioperative pain management and mental health interventions. So finally, talented multidisciplinary team includes expertise in spine outcomes research and patient-reported outcomes with Drs. Ray, Kelly, and myself, clinical operations and surgical quality improvement with Dr. Bruce Hall, psychometrics and analysis of intensive longitudinal data with Dr. Rodaba and Maddie Frumkin, machine learning and analysis of wearable data with Dr. Chen-Yang Liu, epidemiology and study design with Dr. Jay Piccirillo. So thank you all very much for the opportunity to present here, and I'd be happy to take any questions.
Thank you so much, Jacob. So with that, we will ask our judges if you have any questions to start us off. Please either chime in or raise your hand. John, please start us off.
Thank you for that great presentation. Just a clarification on process. So the assessment of the patient's status, those 6, I think it was 6 times before, is that assisted in any way, or is that do you just hand the folks a iPhone-based application or whatever that they manage on their own?
That's a great question. So right now we use a mobile application called Life Data, where we give them a unique account and they download basically an individualized profile. Well, they'll get alerts 5 times during the day at 3-hour intervals that they select that works for their schedule. And then those will automatically come 5 times during the day at those set intervals.
Thank you.
Can I follow up on that, Jacob?
Yep, please.
So you're going to use the individual trajectories from the EMA on a daily basis to predict what happens to them after? I still didn't get the prediction part yet. So you're going to do this retrospectively, collect the data, and then try it on unseen patients? Is that the idea?
Thank you. Yeah, let me clarify that. So our predictive outcomes will be assessed 30 days after surgery, and those will include opioid freedom at 30 days, complications, pain interference assessed using PROMIS, recovery using the surgical quality recovery score. So we'll use for individual patients their preoperative data, so that we'll gather during a 3-week period prior to surgery to then predict those outcomes for those individual patients, both their overall risk and then the individual domains that seem to drive that risk.
And then you're going to use these statistical models to predict individual trajectories. Then you're going to use machine learning to do what? Classify patients who will succeed or not on these outcomes?
Exactly. So machine learning is going to be one of the predictive approaches that we're going to evaluate for how we take these intensive, the psychometric and the Fitbit data that we gather preoperatively, and we use those to identify patients who are at risk of essentially having a poor recovery outcome based on these 4 different dimensions that we're interested in. So the machine learning, and then we're also evaluating regularized regression, will be used to basically identify patients who are at risk of having specific sort of negative events within the first month after surgery that we want to try to minimize and avoid.
All right. Thank you.
Thank you.
Judges, we do have about 2 minutes left in this Q&A, so if anyone else has a question, please feel free to speak up. Clay, please.
Yes, again, you may, nice presentation. Thank you very much. And you may have said it, but how many patients do you expect to enroll?
So we expect to enroll 60 patients for this pilot study. And that's based off both sort of a feasibility assessment and the specific outcomes. So we expect that, in terms of the outcomes that we're looking at, for complications, probably on the order of 25%, perhaps 30%. Opioid freedom as another outcome, we're looking at about 50% at 30 days. And then our other outcomes, the pain interference and surgical recovery score, are assessed on a continuous scale, sort of on a normalized 100-point scale. So we would have basically greater statistical power for evaluating those. So again, our goal is 60 patients, and then we'll sort of maximize our ability to see how well that's going to predict in new samples using statistical techniques like cross-validation to get a better sense of how this would look if applied to a new population.
Thank you.
A quick follow-up on that. Isn't something like pain very hard to predict with a classifier?
So, I think there's 2 answers to that. One is that we're looking at a number of different types of approaches. And so we'd be looking at, predicting the continuous outcomes. And some of those approaches, from a classification standpoint, like gradient boosting trees may or may not be the optimal approach. We're also looking at elastic net regularized for both perhaps predictive advantages, but also incorporability advantages. And the last thing I would say is one of the key advantages that we think we're offering is we're providing a whole new range of predictors based on these real-time symptom data that people have not really applied in this context before. So our hope is that part of this is the models, but part of it is the information we're actually able to bring to those models to really improve those predictions.
Thank you so much, Jacob. And with that, we are at 5 minutes for this Q&A. So thank you for taking the time to answer those questions and for sharing that presentation. I know Zach just joined us. So Zach, if you have any follow-up, of course, the session is recorded and we'll be sure to share that. So with that, let's transition to our 1 minute for our next team, and Amy will be bringing you off of mute. In the meantime, we'll share the polling results for Team 8. And for clinical applicability, we had 70% of our audience rate this as high, 24% rate as medium, 7% rate as low. For feasibility, 63% of you voted this as high, 26% at medium, and 11% at low. And for team composition, 72% voted this at high, 17% at medium, and 11% at low. So thank you again for your participation. And Amy, are you able to come off of mute?
I am off of mute, ready to go.
Wonderful. So I will advance you to your first slide.
So my name is Amy Rick, and I am the Director of Clinical Operations from the Division of Endocrinology. I'm going to tell you about our proposal to devise a novel hypoglycemia prediction model to inform inpatient continuous glucose monitor use. Hypoglycemia represents a serious adverse event that increases length of stay and cost and at least doubles hospital mortality. In fact, there's a patient in the hospital right now who's unresponsive after hypoglycemia and likely won't recover. Our division collaborates regularly with the hospital to evaluate and prevent hypoglycemia, which is now one of the metrics on the BJC scorecard. Continuous glucose monitoring is the mainstay of outpatient monitoring and prevents hypoglycemic events. However, it was not previously approved for the inpatient setting until the COVID-19 pandemic, and will now likely to continue to expand for inpatient use. Because of the increased expenses associated with CGMs, identification of those most likely to benefit will be critical. Barnes-Jewish Hospital is an ideal site to target hypoglycemia. At any given time, there are about 300 patients in the hospital with diabetes. More than 1% of the glucose levels we check show hypoglycemia of less than 70, corresponding to 500 to 1,000 events per month. Severe hypoglycemia, defined as less than 40, where an individual will have cognitive impairment and require assistance, occurs about 15 times a month, and its incidence has been increasing by almost 12% since 2018. This project will utilize levels of C-peptide released during production of insulin, making it a useful marker of endogenous insulin. Low levels suggest significant pancreatic impairment and higher risk of hypoglycemia, but it's rarely drawn by non-endocrine providers. Our project aim here is to create and validate a novel hypoglycemia prediction model utilizing C-peptide to identify individuals who are at high risk for hypoglycemia from a retrospective inpatient data set. Both the use of C-peptide in our predictive model and the use of this model to more efficiently utilize CGM in the future make it innovative. The proposal is also feasible because we've already identified a data set of around 900 patients, and we can assay C-peptide prospectively internally here at the hospital daily with rapid turnaround. So our next steps will be to assay C-peptide in diabetes patients upon admission in order to utilize our model to assess hypoglycemia risk for targeted CGM intervention to reduce hospital hypoglycemia rates. Our team consists of colleagues from both the WashU and the Barnes side, including myself and Alexis McKee from endocrinology, as well as Brian Lizzer from pharmacy, and we already collaborate together to address glycemic control at Barnes. For this proposal, we've also added an informatics team, including Albert Lai and his student, Krithi Bhattari, who will also help devise and validate our hypoglycemia model. Thank you for listening, and I'm happy to take questions.
Thank you so much, Amy. To our judges, if anyone would like to start us off, we do have 5 minutes. Clay, please go ahead.
I'm sorry, I thought I understood, but I wanted to clarify. So you have a retrospective cohort, and you're going to obtain C-peptide assays of them to add to the model. Did I get that right?
Yeah, so we draw C-peptides in the hospital fairly regularly on the diabetes service, predominantly when we're trying to assess whether someone has more of a type 2 or type 1 physiology. So we're going to use that retrospective data to design the model to then look at prospective data for CGM use in the future.
Do you have any concerns that you may have a selected population since they're managed by your service for the retrospective versus the prospective?
There will be some minor differences. I don't think there will be huge differences, to be honest. We see a good chunk of the patients who come into the hospital with diabetes who are at high risk of hypoglycemia. And so I think the populations will actually be fairly congruent.
Great, thank you.
Any other questions from our judges? We do have about 3.5 minutes left. Okay. Well, thank you, Amy, for that comprehensive presentation. And so I'll go ahead and end our polling.
Could I ask Amy something very quickly?
Yes.
So, Amy, thank you. Very interesting. Do you have a sense, because of this is an intermittently detected problem, how much it is under detected? Because you reported of less than 40, and I think you had a frequency of once a month or something like that. But
happens about 15 times a month in
15 times
that
a
we
month.
know of, yeah.
Right, but this isn't something where there's typically continuous monitoring.
True. Yeah, exactly. And so I think that's something we don't have a great sense of. Most of CGM data is from the outpatient setting because that's where it's used more frequently. In general, in the outpatient setting, we look for what they call a time in range of 70%, and we try for no hypoglycemia greater than about 4% of the time, but that's defined as less than 70. Our less than 70 is substantially higher than, I mean, that's close to 1,000 times a month, and that's just what we're detecting. So I think you're right. I think we're seeing the tip of the iceberg. And that's another thing that continuous glucose monitoring will be really revealing.
Thank you.
Wonderful. Thank you. And with that, Amy, thank you so much for your presentation. We will start to transition into our next presentation. In the meantime, I'll share results of our attendee polls. For clinical applicability, 47% of our audience rated high, 38% rated this as medium, 16% at low. For feasibility, 38% of our audience voted this as high, 47% at medium, 16% at low. And for team composition, 34% voted this as high, 41% at medium, and 25% at low. Thank you again for your participation in that poll. And Carla, it looks like you have come off of mute and we can see you.
Are you able to hear me?
We are able to hear you. Thank you very much. So if you're ready, I'll go ahead and advance you to your first slide.
Thanks. Well, good afternoon. I'm Carla Washington, and I'm an associate professor in the Division of Palliative Medicine. And I'm delighted to tell you more about my team's proposal for the user-centered design of a digital health solution to improve symptom management and advanced cancer care. So I've studied symptom burden in advanced cancer care for about a decade, and especially among patients nearing the end of life and their family members who are receiving home hospice care. And time and again, my research has identified a pressing need for us to do more to support patients and their family members who are managing very complex symptoms in the home setting. This focus is well aligned with institutional priorities. On the clinical side, we have BJC Hospice, an indisputable leader in this space, one of the largest providers of end-of-life cancer care in the region. On the academic side, we have Washington University, which has made some very strategic investments in hospice and palliative care research in recent years, enabling our division's federally funded research portfolio to reach in the ballpark of $10 million, most of which come from the National Cancer Institute. So what problem are we trying to address? In recent years, the setting for advanced cancer care has really shifted from the inpatient setting to the community, and it is family members who are the full-time symptom managers for patients who are seriously ill. And we know that symptom management in hospice care is suboptimal. About half of hospice patients with cancer experience moderate or greater pain or shortness of breath in their final days, and we see elevated rates of both anxiety and depression among both patients and the family caregivers who care for them. So we know we have a problem, yet most hospices lack the tools and corresponding processes to support systematic sharing of symptom data. So what can we do? For the past few years, my team and I have partnered with stakeholders to begin developing a tool we call Envision. And I've shown a screenshot of our most recent prototype on the slide for you today. Envision takes data provided from the home by patients and their family caregivers, and it creates simple, easy to interpret data visualizations that are summarized on patient scorecards, allowing hospice clinicians to look at any patient's scorecard and identify poorly controlled symptoms at a glance and to respond accordingly. With the support of the Big Ideas program, we're going to be able to bring this tool to life, to move it into clinical integration and to prepare it for future effectiveness testing. I am delighted to be joined in these efforts by a phenomenal team. Pat Lyons of the Healthcare Innovation Lab, who many of you know, actually worked with our clinical design team in the past and has developed a phenomenal tool. So he knows those ropes and is willing to help us. Patrick White, our division chief, of course, used his BJC project with the big idea support to transform the delivery of palliative care. And Tom Maddox told us a lot about that project as we were getting started today. Finally, the phenomenal Amy Jacobs has agreed to help us. We're thrilled. She's our senior clinical program manager at BJC Home Care and Hospice, and she's going to be instrumental in connecting us with family caregivers and the clinicians we need to make this tool come to life. Thank you so much. I'm happy to answer any questions.
Thank you so much, Carla. Judges, if one of you would please start us off. Yes,
Okay.
Thomas, go ahead.
This is going to be on the patient side, right? What do you envision for the lack of a better term, what do you envision this tool having in terms of a design process, right? Like you touched on some parts of it, but what would your end vision be of this product being used by patients?
So we have two different settings in which we think this tool is going to be really helpful. And one is the home hospice visit, when we envision that hospice nurses, social workers, even chaplains could jointly view these data, these dashboards and scorecards with patients, or more likely, since patients are decidedly ill in hospice, often their family caregivers. So we see that as a setting. They'll input the data, and one of the things we'll hash out as part of N1 is exactly what scale we want to use. The prototype I showed used a 0 to 10 scale, which I really like because I run the analyses. At our clinical partners, they actually know symptom mild, moderate, or severe is probably sophisticated enough. But we'll have a very simple interface on the patient and family side so they can very quickly provide those data. We've done similar research in the past, even pre-Skype, if you will, using Health Buddy devices. And so we know patients and families, if you have a simple and fast enough interface, that patients and families will be able to and willing to invest it in providing those data daily. So we see the opportunity to jointly view, discuss, and problem solve around symptoms during home visits. The other reality for hospice providers is every 2 weeks, CMS mandates what's called an interdisciplinary team or IDT meeting, where care plans are discussed. And the reality over the years watching these meetings is that hospice is growing, which is terrific, right? It's the gold standard in end-of-life care. But you have these incredibly time and labor-intensive meetings where you have the full interdisciplinary team present, and they're discussing upwards of 100 patients and families at any given time. And we're envisioning a scenario in which a patient scorecard could be displayed for the entire team, and they'll be able to prioritize problem solving in those precious moments in that team meeting and make plans to follow up and really support patients and families in a meaningful way that speaks to current needs, because we're going to provide access to data that were collected that day, as opposed to the last time someone happened to be out at the patient's house.
That helps. Thank you.
So I know we have a few questions from our judges. Deb, your hand was up first. We'll then go to Michael and then to Bethany. Deb, you're on.
She's got to do something.
There we go. Okay, thank you. So you've indicated that this is to result in a fully functioning version. Could you just describe the difference of where it's at today and where you're trying to take it to?
Yeah, so we, for years, we're operating with a paper prototype and really have done a lot of formative work, again, been studying sort of this context and the use purpose for a number of years, have a fully developed paper prototype and have published off that, incorporating input, and then have worked with the computer scientists to get a very basic, no bells and whistles version of the tool. And for specific aim one of our project, we want to do some user evaluation, make final decisions on things like, is it a 0 to 10 scale? Is it no, mild, moderate, or severe? Do you want to know intensity of the symptom, or do you want to know how distressful that symptom is to the patient? Because, for example, a symptom like fatigue could be severe for one patient, and that's incredibly upsetting. It could be severe for another patient, and it doesn't really bother them that much. So we don't want to waste our precious resources while we're on the clock with our design team hashing some of that out. So we do have a functional tool. So we are able to get that input at this stage, and then really tee up that full completion of the user-centered design process with our expert team.
Thank you. Michael.
Yeah, Deb asked my question. Thank you.
Okay. How about Ebony?
So first, I want to say kudos to you because I enjoyed reading your abstract because you were so transparent about the R01s. I'm like, perseverance is the key. So I'm like, stick with it. I hope the third time's the charm. But I was going to ask, like, what is your primary outcome? Is the idea that this would be almost like, you know, we put a lot on families and they're by themselves at 2 a.m. So would it be like you instantly get feedback and help? Or is this more of like a long-term tool? I'm just trying to figure out like what will be your measure of success?
So we've had a number of different possibilities in that realm, one of which is actually family caregiver anxiety. When we've actually done statistical analyses and explored psychological distress, we know that this pain and symptom management and those challenges are a key driver of anxiety. We will, of course, be collecting every day symptom data, and we'll be able to see reductions or any changes if they are in fact occurring in patient symptom changes. One of the things in terms of sort of the functional reality, in addition to the ways that I've described previously that we think are going to help the hospice clinician end, we know from studying hospice family caregivers, there are a tremendous number of barriers to them seeking support, some of which may or may not be cultural. We've done this work in rural communities, for example, where people are reluctant to report pain. That's something that we see in lots of different communities. We see it especially in rural communities where there's this notion of toughness and self-sufficiency. We've also worked with family caregivers who are reluctant to reach out, maybe based on misperceptions. They think, well, let's wait until things get really bad to reach out. When in fact, if you reach out earlier, a lot of those symptoms are easier to get under control before all the wheels fall off. We see also wanting to be a good patient, not wanting to be a bother. So we do have those supports in place. So all the tools are there. We see this as a tool that will really activate behavior, certainly on the part of the clinicians, but also on the part of the family caregivers. I'm not bothering you if I get a pop-up that says, hey, I want you to help your hospice do a better job. Could you please call them and let them know that this patient's in pain right now?
Thank you, Carla. We are at time, so thank you so much for your presentation and for answering those questions. We'll share the results of your audience polling, and for clinical applicability, 29% voted this as high, 50% at medium, and 21% at low. For feasibility, 29% voted this as high, 42% at medium, and 29% at low. And for your team composition, our audience rated this 42% at high, 33% at medium, and 25% at low. So again, thank you all for participating in that poll. We are coming up on our very last team here, so thank you all for sticking through the majority of this 2-hour session. And I know Justin has been in clinic, so Justin, we've taken you off mute. Are you joining us?
Can you hear me okay?
Yes, and we can see you, so thank you so much. I'm going to advance you to your first slide if you're ready.
I am ready.
All right, thank you.
Hi, my name is Justin Sachs. I'm the Chief of Plastic Surgery at WashU. The title of our presentation is Clinical Translation of a Device and System for Preventing the Development of Pressure Ulcers. Our device is affectionately called the mercury patch for millimeters of mercury. Next slide. We're trying to solve the development of inpatient and outpatient pressure sores, which occur in the hospital most commonly over the sacrum and the heel. 2.5 million patients a year in the inpatient setting develop this. Tissue death and destruction often goes down to bone, and this happens from 2 to 4 hours of ischemia. This critical time is our opportunity. We plan to integrate our device, our mercury patch device, our pressure assessment device across Barnes-Jewish Hospital and then across the Barnes-Jewish Christian healthcare system to help alleviate and reduce the incidence of pressure sores. Next slide. This is a never event as defined by CMS, along with wrong site surgery, retained foreign bodies, and central line infections. This should not happen in the inpatient setting. 11 billion annual costs to the healthcare system, huge costs per patient on the inpatient side. And this actually even directly results in legal costs, as patients can actually sue the hospital for the development of inpatient and outpatient pressure sores which develop during their care. So this is something that should not happen. And this is something that our mercury patch, our pressure sensing device, which we've invented, is going to help to try to alleviate. Next slide. So our mercury patch, which is a single-use disposable, flexible, and technology-agnostic pressure sensing device, which we've invented here, we've disclosed intellectual property, integrates into a wireless technology. It has 4 sensors, a microprocessor. It goes to a phone or a tablet, and then hopefully we'll be able to get it even into the EMR and to act as a vital sign. We're going to do a nurse workflow survey where we're going to conduct looking at how workflow happens. We're going to do barriers to pressure injury prevention, patient repositioning, how best to integrate the mercury patch. We're going to do a pilot ICU feasibility study, which will allow us to do 20 patients to measure pressure over time and give the providers integrated feedback. And we're going to do an observational study. This is a really strong team of collaborators that touches on all aspects of the healthcare system: a frontline clinician, a clinical trial expert, a biomedical innovator, a nurse administrator who oversees the management of pressure sores in the inpatient setting, and an ICU specialist. Our team is going to work together to reduce pressure sores in the inpatient setting. This is a really big idea, and the reality is that we can help reduce pressure sores to 0. So let's do this together.
Thank you very much, Justin. We will start our Q&A. Judges, if there's someone who wants to raise their hand or just go ahead and speak up to get the question started. Yes, John.
Justin, thank you for continuing to bring innovation to this difficult problem that's been very difficult to make progress on. How will you select the areas, or do you monitor all?
The device was invented to map over the sacrum. So it's in almost like a heart-shaped position. It has 7 sensors, 4 sensors that measure pressure. It goes over the foam dressing, the 5-layer foam dressing, which typically all patients in high-risk inpatient settings get, and it fits right over that. So essentially what it's going to do is it's going to go over the sacrum, which is the highest incidence of pressure sores in the inpatient setting here in our hospital and across other healthcare systems. And then it'll give almost like a vital sign. So like pressure, temperature, blood pressure, on pulse, it'll give actionable information. So if the pressure is elevated quicker than an hour, we know to turn the patient. It's a very simple intervention, but it's something we don't have right now. Normally we turn patients every 2 hours and we hope we reduce pressure ulcers. This is not working because we are continuing to get pressure sores in the ICU and the outpatient setting. So it'll help guide us with actionable data that doesn't exist. And it obviates the need for big beds that cost a lot of money, or big pressure map systems, which can cost $10,000 or $20,000. This is a cheap single-use disposable device that we want to integrate into Epic that's patient specific. And hopefully we can scale this across the system because we can make more of them for less.
And I do have a prototype. Sometimes it's helpful to see it in person. So this is the mercury patch. It's really soft and flexible, super thin, and it just fits right on top of an Alleven foam dressing. So it's not in contact with the patient. So that helps, you know, if you needed to change it for hygiene reasons, you can just throw away the foam dressing and, you know, put this onto a new one. So.
I just want to follow up on what you just said, Justin, about integrating with Epic. Is there some sort of interface that can be connected in order to make this data available in Epic?
Right now we have an app that we've created that goes to a technology agnostic platform. So it can go to a smartphone, an Android, a tablet. The idea would be then to take that information in a HIPAA controlled way and then just integrate it into Epic. And that's something that we would have to work on with BJC, but it's definitely doable because it's Bluetooth technology and it can be routed right from the patient's backside to the computer. That's something that I can't get too deep in. If Matt McCune was on, he'd be able to answer that on a little more technical side. But it's a Bluetooth sensor which transmits to a phone, so we can probably route the same information to a server, which would go into Epic and then come up just like Pulse.
Yep.
pressure. You'd have pressure waves. So you'd look at 16 monitors and you know that somebody's been sitting for too long. Or if it's going up and down, you know they're walking. And this could be done in the outpatient setting too. I see a lot of patients who come in with wheelchair bound, paraplegics, quadriplegics. They would love this because it would tell them to turn. As I mentioned, it's a way using technology to leverage the scale of the system and the Epic platform that we have that's begging for these kind of devices to be invented around it.
Thank you, Justin. Michael, you have a question, and we have a little over a minute.
Justin, thank you. Very interesting idea. You talk about it being evidence-based. Do you know at what pressure this risk increases, and is it patient-specific?
So it's a great question, Dr. Avedon. So at 32 millimeters of mercury and pressure and capillary pressure, if you have that for longer than 2 hours in skin or fat or muscle, you get ischemia. That's animal models, that's human models. We see that all the time. Every patient's different. We actually see more pressure sores in the ICU in cardiothoracic, thinner patients on vasoconstrictors. So we actually think that the 2-hour dogma might be wrong. It might be you get pressures after 1 hour, or we'll put these in the operating room. We might find that we're getting sacral pressure sores developing in the operating room. And it's not the ICU, because I don't think it is the ICU. I think it might happen earlier. So the pressure patch in the operating room might show that you're getting a lot of sacral pressure. We can offload that if we knew the data. Right now, it's like you're flying without GPS in the operating room. You have no idea what the sacral pressure is. So this might be a way to integrate in there. But we do know that 32 millimeters of mercury, more than 2 hours over time, will start to cause necrosis. And usually the necrosis happens down in the muscle. You don't even see that for a month later when I see it in clinic with dead tissue or dead bone.
Thank you.
Thank you so much to Justin and Amanda for that presentation and demo. We are at time for this Q&A. With that, I'd like to share the results of the polling question for this team. And so for clinical applicability, 76% of our audience voted this as high, 17% at medium, 7% at low. For feasibility, 55% of our audience voted this at high, 28% at medium, and 17% at low. And for team composition, our audience voted 59% at high, 34% at medium, and 7% at low. Thank you again for your participation. And with that, we have concluded our last team. So we will hand this over to Philip Payne for our closing remarks.
All right, thank you, Allie. So I'd just like to start by saying congratulations to all 11 teams that presented today. I think it was an impressive series of pitches. And I think in particular, it really showed the breadth and depth of the projects that have evolved underneath the Big Ideas program over the last 3 years. Just today, we saw presentations that spanned a spectrum from how do we leverage wearables and sensors to improve care delivery and enhance wellness, to how do we use analytical methods and AI to support better clinical decision-making and personalized risk assessment, to our final presentation where we looked at novel devices that would allow us to identify and mitigate adverse outcomes for hospitalized patients. And again, I think this really shows the power of the Big Ideas program and how we're harnessing this innovative thinking at BJC and Washington University. So again, congratulations to all 11 teams. I would like to take a moment and just thank a few individuals, actually quite a few individuals that made today possible. I want to start by thanking our judges who took time out of their busy schedules, and I think we could all agree asked a series of very thought-provoking questions about the presentations. And in particular, I'd like to thank Michael Avedon, Deb Odell, John Lynch, Clay Dunnigan, Ebony Carter, and Thomas Conopal for, again, their effort on behalf of the Big Ideas program and for helping our teams to discuss and think through their proposals. I'd also like to thank our partners at Avia for being part of today's event. And just thinking through sort of next steps, because I think our teams as well as our audience are probably wondering what happens now. So on May 3rd, we'll be looking for full applications from our teams that presented today. And by May 17th, we'll actually notify the winning teams. That's one of the things I love about this program is the speed with which we're able to get to decisions on these innovative projects. And on May 19th, we'll let everyone know about the winning teams and projects and what work we'll be undertaking in this next round of Big Ideas projects. And so again, as I said, this is really all about the innovative thinking of our leaders and caregivers and researchers at both BJC and WashU. That's why we created this program. And I think in particular, it shows the power of collaboration between our organizations, between all of those individuals in order to catalyze projects that have real world impact, because I think that's a central part of all the proposals that we saw today. And real world impact for the patients and the communities that we serve, which is really the ultimate goal of this program. And I think when we bring this all together, we really have an opportunity through this mechanism, and we've seen it over the past 2 years, and we hope to see it again with this year's set of applications, where we can take these big ideas and turn them into projects with real world impact. And before we wrap up today, because I know we're coming up just on time, I also want to thank a few more individuals that really did the real work behind today's event. And I think I can extend these thanks on behalf of both myself and my friend and colleague, Dr. Maddox. And I'll start with the team from the Healthcare Innovation Lab, including Ali Cosador, Jackie Jones, Kyla Hurley, and Megan Nelson, all of whom did a tremendous amount of work to help organize things. And also from the Office of Health Information and Data Science, Cynthia Marich, Andrea Krussel, Laura Swafford, Janice Woodcock, Lucas Steinbeck, and Lynn Zhang, all of whom did a tremendous amount to make today's event possible, and also Carter Staley. And I want to thank all of you in the virtual audience for staying with us for the last several hours and participating in today's event. Obviously, we wish we could have done this in person, but I think we all look forward to next year's event, where we hopefully will be doing this in person. And with that, I think we can draw today's event to a close. So thank you.